Hello friends, welcome back to my channel with a new video on meningitis, and this is the final and the third video on the same topic. So let us start with the treatment modalities, and this is one condition where a clinician or an intensivist should not shy away from giving an empiric antibiotic as early as possible, uh, preferably within 1 hour of arrival, and it should be combination of either a third or fourth generation cephalosporin, predominantly in the form of ceftriaxone or maybe even cefepime, because it can have a good blood brain barrier penetration, along with vancomycin, because we are treating most likely the MRSAs, the community acquired MRSA, and of course acyclovir if you actually suspect a HSV encephalitis. So this is the mainstay of the initial choice, and of course with the adjunctive therapy in the form of dexamethasone, which is given in the dose of 10 milligram every 6th hourly, especially for bacterial meningitis. You may have to give ICP lowering agents. In few situations, anticonvulsants are required if the patient has seizures, and of course, you give a hydration and try to correct any electrolyte abnormality if the patient has, especially the hyponatremias. As far as the viral meningitis is concerned, it can also be termed as aseptic meningitis, which is not very uncommon. Usually, it is a self limiting disease with a fairly good prognosis, more commonly seen in younger individuals where you have or you encounter photophobia, and it's generally preceded by any viral illness like condition before they have features of meningitis like upper respiratory tract infections or GI symptoms in the form of nausea, vomiting, or diarrhea. And we have seen how the CSF picture looks like in viral meningitis, where you could actually remember that chart which we shared in my second video. And there is another very important aspect, and we had a case recently in our ICU where the patient was relatively young patient, was in my ICU, shifted from some other hospital where the neurosurgery happened, and he was probably in his eighth or ninth day of illness. Uh, he was like unresponsive, uh, and was breathing on TPs, but he had persistent fever all the time. So, any such patient who comes to you where the fever is not diagnosed, usually they present with a very high grade fever. You may or may not have neck stiffness, and it's very difficult to actually appreciate that. You should always suspect a post neurosurgical meningitis. And in our patient, we suspected that. We did a CSF in spite of the fact that the primary consultant was reluctant to go ahead and do a CSF. But probably we did a CSF after 48 hours of admission, and we proved that it was meningitis. So remember that when you are on rounds, you need to find a plausible explanation for the fever rather than just labeling them as a VAP or a urinary tract infection, which exactly happened in our case. So this particular scenario is seen in after the cranial surgeries in the frequency of about 0.3 to 8%. Placement of the intracranial shunts, which is seen in about 4 to 17%, and ventricular drains from ranging from 0 to 22%. And it runs a very severe course and high mortality, which can cause neurological sequelae. Diagnosis, as I said, is very difficult, but you should have a high index of suspicion. Put the things together, them in the proper context. Uh, and especially with this patient having neurological compromise with potential sources of infections in the other form, like, uh, as I said, UTIs or VAPs, and catheter induced or central line induced fever with uh, invariably receiving lots of pre existing antibiotics. So the causative organisms can be either coagulase negative Staph aureus or Staph aureus or MRSA, the Propionobacterium mechanis, aerobic gram-negative bacilli, Enterobacter, Acinetobacter, and Pseudomonas. And I remember we actually had culture growth of Acinetobacter in this patient. So they presents with new headache, fever, nausea, altered mental status. There can be evidence of meningeal irritation. At times there can be seizures. They can also have peritonitis, abdominal tenderness, local erythema, especially for the patients who have VP shunt, and of course fever with evidence of CSF leak. So in our patient, I remember this patient had CSF rhinorrhea. As far as diagnosis is concerned, do a lumbar puncture, send the CSF straight away for gram stain and culture, which is definitive. CSF lactates are very important kind of investigation in this subset of patients. CSF PCR test, do a CSF beta D glucan and galactomannan assay, especially to rule out fungal meningitis. Do a blood culture, and of course, send a CSF and serum procalcitonin. As far as therapy is concerned, start them straight away on vancomycin with a combination of anti-pseudomonal cover, either in the form of cefepime or ceftazidime or meropenem. And I clearly remember we starting him on ceftazidime avibactam plus vancomycin combination. If beta-lactams, which cannot be given, aztreonam or ciprofloxacin is an alternative. Aerobic gram-negative bacilli, we may prefer third generation cephalosporin or meropenem. Acinetobacter, as I said, we may prefer meropenem with colistin, but as I said, we have had, the patient has received meropenem for a very long time. Candida, you may prefer liposomal amphotericin B and fluconazole. And of course, aspergillus, where the drug of choice is voriconazole. So, another case which I remember had a post trauma meningitis where this patient required intrathecal colistin uh, for at least 2 weeks, and we had involved a ID physician who had extremely valuable insights on this particular case. So, having said that, I think this is a very important subset. Although the video was very short, but I thought it's important to cover this post neurosurgical meningitis as a case, very important case scenarios in our day-to-day practice. So that's all for now. Let's meet in my next video. Before I forget, please like, share, and subscribe my channel. Thank you. Bye bye.